So going by the definition, it is a more of a generalized term, disorders of any cause. It is a very heterogeneous term, involving the sensory nerves, motor nerves, or maybe both, usually in the PNS. It is exclusive of the ANS. One nerve, mononeuropathy. It may affect a bunch of nerves together. That is called as polyneuropathy. Now, if those bunch of nerves affected together are in a common distribution area, it's called as polyneuropathy. Now, it is sometimes possible that these nerves might be in different areas but still affected temporally in the same time. So at that point of time, mononeuropathy multiplex. You will understand more as we go on. So now there are affections which cause problem at the level of the cell body. It could be a ganglionopathy. It could be affecting the myelin sheath of the nerves, so it is called as myelinopathy. And finally, if the whole of the axon is involved, it is called as axonopathy. So the crux of the difference for you people is to identify myelinopathy pattern versus axonopathy pattern. So that is, where is the lesion, then what is the lesion, and then why is the lesion. Ultimately, that are the three questions in the earlier class in approach to neuropathy in phase 1 of your teaching. So let's go on to the most common causes first. Obviously, the first most common cause worldwide is diabetes. So any patient coming to you with, this is from BMJ, the first any patient coming to you with any sort of symptoms, be it positive symptoms or negative symptoms, you first need to inquire about the history of diabetes. It has a prevalence of almost 11 to 41% in diabetes, neuropathy per se. The next most, paraproteinemia. Now, paraproteinemias might be there in disorders like multiple myeloma, MGUS, other clonal disorders of the blood system, so hematological system. That is one cause which involves the nerves also. Thirdly, alcohol misuse. The third most common cause, preventable, reversible to a large extent, is alcohol misuse. See, diabetic neuropathies, paraproteinemias, if they can be cured, and alcohol, these are all reversible causes. So we are all looking for causes which we can treat first, and they are the most common ones. Renal failure, 4%, you can to an extent help, maybe, and then giving drugs. Vitamin B12, which this is actually US data, Indian data, B12 deficiency is much more common amongst vegetarians. So that is also one reversible cause. It should always be in your mind. Then coming on to HIV. Our hospital is the center of excellence for HIV. Obviously, we are seeing a lot of HIV patients, and these HIV patients, even after starting off ART drugs, and sometimes even the drugs themselves, might cause neuropathy. Coming on to chronic idiopathic axonal neuropathies. Now the incidence varies between different hospitals depending on the level of referrals. Let's say tertiary care might be 4, but that varies from 10 to 40%. So these are the crux: diabetes, blood disorders, alcohol, CIF, B12 deficiency, and HIV. These 6 top of your mind whenever you are thinking of a neuropathic disorder. So just let me first clarify one thing. Class which I took of Introduction to Neurological Disease, I think Dr. Sunita had taken another class. Then there will be a class of hemiplegia or maybe paraplegia by senior faculty again. These are the cases which you are getting in the final year exam. Neuropathy, you also might get a case if it is there in the ward. So you need to establish first of all where the lesion in the CNS is. The patterns of involvement of weakness and the sensory patterns give you a clue. Let's say it is hemiplegia, it is quite clear it will be in the cortex. Or paraplegia, it is quite common in the spine. Now, if you are getting a case of quadriplegia with no reflexes, now this disorder might be present at the nerve muscle, at the neural or the nerve part, or maybe at the junction, or then going on even below the nerve at the. Okay, I'll speak slow because I can't increase the internet speed that the college is providing me. But yes, obviously I can go slow. So this is a common slide. This has been taken from not from a neurology, but rather an endocrinology book, which gives you very clearly the large A fibers, then the smaller fibers, and the thin unmyelinated fibers. Can you see the arrows? So when we are looking at motor neuropathies and myelinated fibers, these are the A alpha variants which are usually affected. Then the sensory fibers is the overlap between two. Can you hear me clearly now, or is it still breaking? Hello, am I clear, or is the voice breaking? Let me switch to a different internet source. So is the voice now audible? Is the voice clear now? Okay. So let's go on to the after the fiber classification. I what basically want to stress over here was that when you are looking for motor symptoms, always think of the larger fibers. Sensory symptoms, look for the smaller fibers, and autonomics like heart rate, blood pressure, sweating, GI or GU disturbances, gut disturbances, urinary tract, then look at the autonomic functions. Okay, so when we look at the large sensory fibers, there might be a constellation of either a positive symptom or a negative symptom. In neurology, either a symptom is absent, a loss of symptom is taken as a sign, clinical important landmark, or a positive symptom might also be taken in case of neuropathy. So what are the negative symptoms? Decreased touch, decreased proprioception, and loss of reflexes, or reflexes might become sluggish. So that is in case of sensory ataxias, this is a constellation of large fiber symptoms. Same way, if there is a presence of paresthesias, this is a presence of positive symptoms involving the sensory large fibers. Now, when you look at the small fiber disease, there might be decreased pain and temperature. So when you do CNS examination, when you are looking for all modalities, be very clear that which modality has decreased. Is it just pain and temperature, or is it vibration and proprioception, which are the posterior columns? If the lateral columns have the modalities of lateral columns have decreased, there might be a problem with small fibers. And if it is the large fiber, these are the problems you might encounter. At the same time, positive symptoms, paresthesias for large fibers and dysthesias and allodynia for positive symptoms for small fiber. Am I clear with the sensory symptoms? This should be coming in your chief complaint, usually which manifests and is corroborated in your clinical examination. Next, we are looking at motor nerve injury now. There are some pure motor nerves or mixed nerves, and motor nerve injury with the large fiber, the negative symptoms might be wasting, hypotonia, reflexia, orthopedic deformity. These constellation of symptoms usually is encountered in mononeuropathies. So when it is a mononeuropathy, usually the first thing which comes to your mind is entrapment, and it is usually an orthopedic phenomenon. However, disturbed positive symptoms like fasciculation and cramps, these might even occur in diseases like anterior little sclerosis or early demyelination, is more seen in medicine. So loss of symptoms and gain of positive symptoms like fasciculation or cramps, you need to document and HOPC if the patient doesn't tell you. Now the third is, what is the history pertaining to autonomic nerve injury? For autonomic nerve injury, you need to look at symptoms of decreased sweating, hypotension, urinary retention, impotence, and vascular, that is color changes in the periphery, usually in the hands, arms, legs. And what are the disturbed positive symptoms? These are increased sweating, hyperhidrosis. That is also again dysautonomia or hypertension. See, hypertension has so many different causes, so any hypertension should not be attributed to autonomic nerve injury only. After ruling out the common causes, then you might put it in the whole picture, right? Don't take this as a singular symptom. Otherwise, this constellation of symptoms which I am pointing out might be present in dysautonomia. So what we have clinically now described is positive and negative symptoms pertaining to sensory system, motor system, and autonomic nervous system. Let's go on. This is all as a master chart, right? I'll spend some amount of time over here. This is from Harrison's only. And now a patient comes to you and see, what does neuropathy mean? Patient यही कहेगा कि मेरे को हाथों पैरों में झंझनाहट होती है, या चलने में, या दिक्कत, सामान पकड़ने में दिक्कत. आप देखोगे तो उसको स्वेटिंग शायद हाथ पे कम हो रही होगी. This is a constellation and it will follow a typical pattern. What we usually see is a pattern of glove and stocking distribution. आप हिस्ट्री लोगे शायद उसको डायबिटीज मिलेगा. So this is the pathway when we are proceeding towards polyneuropathy. Let us take another scenario. डॉक्टर साहब, कल मैं रात को थोड़ा ड्रिंक कर लिया, सो गया कुर्सी पर ही कंधे के बल, और मेरा राइट हैंड जो है वो बिल्कुल लंब है, ना सेंसेशन है, ना अंगूठा और उंगलियां काम कर रही है. Now this, as we look the first pathway, mononeuropathy. This is the first case I am describing, right? Mononeuropathy or entrapment at the axilla. Saturday night palsy, very good. So now this lesion is simply compression, and most of them are resolved by observation. So there is no need to take a call on surgery right now. You might take a surgery consult. The first one which I described was polyneuropathy. Now, if the history and examination are compatible, look at this first. If these are compatible, then you go on to the next step, which is usually workup, clinical examination. If your examination also suggests it is polyneuropathy, then you go on to Electro diagnostic studies. We will discuss those, and then axonal or demyelinating. Now, if it comes out to be a chronic course over years, you will be thinking of, in case of diabetes, you will be thinking of diabetes. In other cases, you will be thinking of the appropriate things. We will discuss this table. I'll come back to this table again and again. This is the master chart of this whole class. Then how does mononeuropathy multiplex present? See, I will take cases. Let's examine a patient who is having For a moment, let's take a patient having vasculitis with underlying maybe SLE or maybe some paraproteinemia or a multifocal process, systemic process. So in this case, the patient will have, let's say, features of left radial arm palsy. There might be cranial nerve facial palsy or even sarcoid. The patient might be having then cranial palsy and then right lower leg palsy. But these are not occurring simultaneously. These you will be taking a history. One of the weakness in one arm resolves, then facial palsy set in, and then the leg weakness sets in. So there is a temporal distribution, but there is a slow resolution, but not complete. So this will be the typical history. अलग-अलग जगहों पर अलग-अलग टाइप की पावर लॉस और सेंसरी लॉस के साथ प्रेजेंट कर रहे हैं. And then you go on for compatible blood testing, other special investigation, and electrodiagnostic testing, right? You find that on electrodiagnostics it's an axonal issue, then you will be thinking of vasculitis and other causes. You sometimes even require a nerve biopsy. Once you get a diagnosis, treat the patient. The very good thing about is यूरोलॉजी में कहते हैं पेशेंट को कुछ खास ट्रीटमेंट नहीं मिलता, ऐसी बात नहीं है. इफ यू डायग्नोज अ न्यूरोपैथी properly, you look at the cause, you give symptoms, patient will be much relieved, and sometimes if it is a reversible cause. The thing is how intelligent you are to find the reversible cause. Okay, so let me go to the next slide. We'll come back to this once we take the cases. So mononeuropathy, what is the typical classical presentation? We'll take 3 cases at the end. Please be prepared. It should be voluntary. It should not be कि आप करो, ठीक है? Please present one mononeuropathy, one multiplex, and one polyneuropathy examples. Just a simple brief history, like the case scenarios we discussed last time. ठीक है? 5 minutes each. Just prepare some of you. Mononeuropathy is usually a focal involvement of a single nerve and implies a local process. I described in the table. There might be direct trauma, compression, or entrapment. See, there might be a stab injury. So you understand at the level of a stab injury, if there is, or let's say fracture of a underlying bone, it obviously will need orthopedic intervention. Sometimes what happens is there is neoplastic compression, let's say in a leiomyosarcoma. So there might be neoplastic compression or infiltration leading to mononeuropathy. So most of these are quite apparent. You don't have to look for universal systemic processes over here. Next is mononeuropathy multiplex. As I told earlier, it is simultaneous sequential, either of the two, damage to multiple non-contiguous nerves. The pattern becomes very clear. So small skeleton and draw out the pattern. कि कौन सा कब से कब draw हुआ, that small skeleton which you draw. I'll just show you how you do it. Make a small skeleton. So if there is cranial neuropathy, you can put it in a box over here. If there is any spinal involvement, you can put it in a box here over here. These two will exclude neuropathic involvement. This will be a systemic process. And now, once these two are excluded in the history and examination, you look at this. You put, let's say for power, you put power of 3. And since when it was involved, motor or sensory. This is while you take the history examination so that you can consolidate it. So right upper limb was first involved with a motor loss of, let's say, 2 grades, so it became 3, and then it slowly improved. And later on, what happened was that the nerve below the knee on the left lower was involved. Into this improved meanwhile, and then again it was a pure motor palsy. So this is the history you might be getting. Let's say in some heavy metal poisonings or vasculitis or neuropathic processes, or maybe even leprosy. Anson's it's called thickened nerve. So this is what mononeuropathy multiplex will look like. Am I clear with this? Next. Now, polyneuropathy is one of the most common things we face and most likely in diabetics. So it is characterized by symmetrical distal motor and sensory deficits. See, diabetes has also patterns, and that is a question which will be asked to you. But as a prototype, symmetrical distal motor and sensory deficit that have a graded increase in severity distally. Usually it is a distal, so I told you glove and stocking pattern. Distal attenuation of reflex. There is loss of both motor and sensory power, and rarely it is predominantly proximal, like acute intermittent porphyria. See, porphyria is something which is actually very, we might ask one or two cases at max. So don't go on and diagnose everyone as porphyria. The first thing should be always be diabetes or B12 deficiency or some other malignant processes. So patient says मेरे दोनों ऊपर के हाथों पैरों में simultaneously और नीचे के हाथों पैरों में झंझनाहट और वीकनेस होनी शुरू होगी, जो कि पाउं से और डिस्टल टिप्स ऑफ फिंगर शुरू हुई और अब ऊपर की तरफ जा रही है. दैट इज द ग्लव एंड स्टॉकिंग पैटर्न ऑफ पॉलीन्यूरोपैथी व्हिच is usually followed, right? Sensory deficits follow this pattern, motor may not. So this is the typical pattern which you might be getting in exam. Mononeuropathy you might get in orthopedics, maybe not in medicine. Polyneuropathy multiplex, if a case is there, you might get it. But sorry, mononeuritis multiplex. And polyneuropathy is no audio. Is the audio there? Can you hear me? Okay, so somebody wrote no audio. Polyneuropathy is this is a typical pattern which you would be describing in cases. Let's say somebody has this with diabetes. So this is the pattern of polyneuropathy. This is sensory loss. Marking for sensory loss. And this is the marking for motor loss. And this is the overlap. Polyneuropathy, this is both sensory and motor overlapped over here, and over here, right? You can also write the power everywhere. However, see, mononeuropathy multiplex, the involvement of one particular nerve territory, then another nerve territory, and then one another. So ulnar here, maybe radial here, and then maybe peroneal, common peroneal, and early part maybe femoral over here. So it's a multiplex, different nerves being involved. So when we talk about axonal degeneration, we should be understanding what does it mean. It is basically a pathological reaction of a peripheral nerve. It is caused by, now listen to the causes very carefully. It is usually a systemic metabolic process like diabetes, right? A toxin exposure like lead, and some inherited neuropathies. You will be asked many times in MCQs what is dying back or length dependent neuropathy. They will not write axonal. They will write dying back or length dependent. So remember, this term just means axonal. And then what happens is the myelin sheath, which I showed in the initial part of the A alpha fiber and maybe up to the beta, the A alpha and maybe up to the gamma. The myelin sheath breaks down along with the axon in a process that starts at the most distal part of the nerve fiber, and then it progresses towards the nerve cell body. So this is what exactly axonal degeneration, when you mean, again no audio. Ekta, is the audio to you, or is the whole class not getting any audio? Please write in the box, are you, all of you, not getting any audio, or is it just Sita who's not getting any audio? Breaking a little is all right, but no audio means no audio. Let me switch networks. Just a moment. Am I loud and clear now? Is the audio fine? Okay, so we can continue from here. However, now when we are contrasting from axonal to demyelinating, what is happening in demyelinating is there is a sparing of the temperature and pinprick sensation. There is an early generalized loss of reflexes mediated by the motor fibers, large fibers, and it might be acute to a subacute presentation. Just keep GBS in mind, right? There is very disproportionate mild muscle atrophy. DDRs are affected. Reflexes are lost as a prototype. Then presence of proximal and distal weakness is there. Proximal is usually more than distal or equal. Neuropathic tremor might be there in some diseases like CIDP. Just you can forget this or skip this. There might be palpable enlarged nerves if, however, sometimes infiltrative disorders are there, and in CSF there is a albuminological cytological dissociation. So GBS is a prototype demyelinating neuropathy, but that is acute. GBS is called as AIDP, acute inflammatory demyelinating polyneuropathy. So remember, in the first chart which we used, the prototype was GBS. So remember GBS, remember demyelinating polyneuropathies. In medicine, it is said that you need to remember cases. You can't just remember text. तुमने वार्ड में जाकर केस देखा होगा, उस पर डिस्कस हुआ होगा. That is what you will be remembering the rest of your life. Okay, we saw 3 cases of GBS. So that is a prototype demyelinating neuropathy. And when your exam comes, you can simply remember that case and write down what were the findings. That is usually how you remember medicine, case-based discussion. You just can't remember it by a virtual class. It just can't be remembered just by going to the patient. Thirdly, you need to read also. So integrate all 3 things. So these are the patterns I will like to discuss at the end. There are 9 patterns, but I won't confuse you. Let's start looking for clues for diagnosis. So the patient comes to you with constitutional symptoms of weight loss, malaise, and anorexia. You are a very physician, I must say. You take a very good history of all the reversible causes. You first of all, क्या आपको पहले से कभी शुगर पता था या है या कभी टेस्ट करवाया? Secondly, if there is a family history, you go on to hypothyroidism. Patient को देख के ही लग जाएगा the patient might be hypothyroid. You ask for oliguria, hypertension, anemia, the triad of chronic renal failure. Patient नहीं आके बताएगा कि मेरे को CKD है. You will be asking for symptoms, right? Then chronic liver disease or any treatment going on for malabsorption. Chronic diarrhea तो नहीं रहता. Then malignancy, obviously, if somebody is having malignancy and presenting to you with polyneuropathy, the patient will be telling you कि डॉक्टर साहब इतने साल पहले ये malignancy हुई थी, उसके बाद कीमोथेरेपी चली थी, right? Then you go on to connective tissue disorders. Somebody is having SLE, obviously if renal involvement precedes neuropathic involvement, they would already be knowing कि हम ये फलानी दवाई खाते हैं. HIV I put in the bracket because we don't call it as HIV, we'll call them as PLWHA, people living with HIV/AIDS, right? So we just even don't write on the file due to the stigma involved, but you can very confidentially in person, not other obviously relatives being there, whether the patient is receiving treatment for HIV, any drug use, or vitamin B6 over toxicity sometimes also causes neuropathies. There are people who just gulp down vitamins. This has happened in the COVID era also. People are taking mega doses of zinc and vitamin C. So it's a fad outside. You get whole big bottles of multivitamins and they keep on taking it for years without consulting their physicians. It's all right, you take it for a short while in the prescribed doses, but once you exceed the RTA, that itself might cause toxicity. Then alcohol is definitely a very big etiology. And then dietary habits, vegetarian or non-vegetarian. This is a typical history you should be taking in all for risk factor. Now, what are the conditions associated with painful peripheral neuropathies? Diabetes, alcohol, chemo. When we describe neuropathies, the patient might come to you with pain. So, pain is more important. Treat the pain first. Etiology, patient can wait. Pain should be treated. Having that neuropathic pain, they will not be coming to you again and again. They'll give you 1 or 2 chances to treat them properly. Just a moment. Paraproteinemias after chemotherapy, then vasculitis, heavy metal toxicity, HIV, amyloid, and porphyrias. These are all causes of painful neuropathy. I have a whole list and these might be asked to you anywhere in exam and MCQs, but just focus on what I have given as read. Isoni as it. Okay. Antitubercular, metronidazole, so commonly used in diarrhea. Every second, third patient you prescribe Ciplox and metronidazole. Lithium, chloroquine, amidron. Just go through this list for a moment. You might even take a snapshot. These are so the next is there is a pattern of proximal symmetric motor polyneuropathy. The prototype which you might be getting after diabetes. Are you getting the audio now? I had muted. Prototype, is the audio there now? Okay, so the prototype, I have marked them in red. This is a whole list again. You need not remember whole lists from the books. Just remember, you might be getting a case of GBS. You might be getting a case of diabetes presenting with symmetric proximal polyneuropathy. You might be getting a blood disorder, MGUS. Can somebody write in the text box what MGUS is a spectrum of? MGUS. Question box. Yeah, it's not multiple myeloma, it's a spectrum of multiple myeloma, something less number of plasma cells in the marrow. Then going on to lymphoma, you had a very nice discussion that day, right? Okay. Thank you. You had a very nice discussion that day on, I think, hepatosplenomegaly and fever, and you might be seeing patients of lymphoma. So that might present in this manner. Then HIV/AIDS, obviously, I told you we are the apex center of all of Delhi, and then hypothyroidism. So just remember the red ones: 1, 2, 3, 4, 5, and 6. These should always be there in your mind whenever you are seeing proximal symmetric motor polyneuropathies. Now come down to the history. What I was discussing till now was the background knowledge कि patient को temporally क्या क्या रिस्क फैक्टर्स हो सकते हैं, पेशेंट को इटियोलॉजीज क्या क्या हो सकती हैं, और पेशेंट की प्रेजेंटेशन कैसे हो सकती है. इनिशियली हमने डिस्कस कर लिया कि सिम्टम्स क्या क्या होंगे, और उससे पहले हमने डिस्कस कर लिया था, आई एम जस्ट रिकैपिचुलेटिंग, कि किस पैटर्न में प्रेजेंटेशन होती है. अब नाउ कम डाउन टू अ पेशेंट एनकाउंटर एक्चुअली you and you are taking a history. So neurology, the main crux of the case discussion is history. Once you are thorough with your history and you can summarize the case well, I think it's 70% of your job done, right? So just now concentrate on what the important points in history are. The temporal course of neuropathy varies based on etiology. We can't say कि अगर diabetes है तो वो भी same pattern follow करेगा as a blood dyscrasia. So the history will have to be written once you are through with the hematological aspects, the endocrine aspects of different diseases. Maybe by the end of the year, you will be understanding polyneuropathy in a much more better form once you are through the theory part. So let's say with trauma or ischemic infarction, onset will be acute. Obviously, अगर किसी को fracture हो गया मोटरसाइकिल चलाते चलाते और उसके साथ मोनोन्यूरोपैथी हो गया, वो chronic history नहीं लेके आएगा, वो एक दिन की history आपको acutely बताएगा. However, the patient has some inflammatory and metabolic neuropathies. This will be subacute. For all practical purposes, हम acute कहते हैं lasting for days, सब एक्यूट कहते हैं वीक्स एंड क्रोनिक कहते हैं मंथ्स. कई बुक्स, ज्यादातर बुक्स, दे आर फॉलोइंग दिस पैटर्न ऑफ लेस देन 4 weeks to 6 weeks, again chronic. Just remember the chronicity will vary according to the etiology. Now a chronic course over weeks to months. I'll take a case also in the end, who's, let's say, a painter by profession from the last 20 years, when there used to be some toxic substances in the paste, and is now, after cumulative exposure of years, coming to you with history of polyneuropathy of motor nerves, suspecting some sort of disorder. I'll take a case at the end. You'll realize that taking out a history of poisoning or metabolic neuropathies in chronic diseases will actually require the best of clinicians putting their minds together. It might not be lead, it might be so many things, not just lead. I appreciate the answers coming in. So next is a chronic slowly progresses with hereditary neuropathies, or is called as CIDP. That might be manifestation, might mimic some other things. Neuropathy is a relapsing and remitting course. उसके CIDP, RF subs, HNPP, इनको हम रिपीट नहीं करेंगे, ये PG लेने ज्यादा है. हिस्ट्री में इस्कीमिक न्यूरोपैथी में पेनफुल न्यूरोपैथी है कि नहीं है, जस्ट टेक अ क्लियर हिस्ट्री ऑफ दिस. एंड स्मॉल फाइबर न्यूरोपैथीज के लिए टेक अ हिस्ट्री ऑफ बर्निंग पेन, लाइटनिंग पेन, लैंसिनेटिंग पेन, द टाइप ऑफ पेन दे प्रेजेंट विद, aching, or just uncomfortable paresthesias. You need to differentiate which modality of pain sensation is being affected. Now, as I told you, in dying back neuropathies, what involves is the progress proximally in a stalking. This becomes more or less clear through the history. Peripheral neuropathy can also present as restless leg syndrome. Proximal involvement may result in difficulty climbing stairs, lot of lifting, and bulbar involvements. Sometimes like drooling of saliva might also be seen. Now the clinical involvement, the assessment should include care for past medical history. उसने क्या क्या दवाइयाँ खाई हैं, उसको क्या क्या बीमारियाँ हुई हैं. Diseases which are associated with neuropathy. I am repeating the same thing maybe 10 times, but I think stay in your brains so that you keep remember these things facing a case. Ethnicity and globalization. See, there are diseases prevalent in different parts of the world, in different regions of India. Just remember that has a very significant history. So the socio epidemiological history, patient is a resident of what place, right? Then dietary history, patient खाता क्या है, उसको किसी चीज का chronic exposure तो नहीं है, लेकिन non vegetarian. Then a family history, खाता क्या है में vitamin underdose और overdose भी बहुत important. Family history in hereditary neuropathies, drug history, suppose कोई continuously drug abuse कर रहा है, which has become so prevalent nowadays, right? Ganja taking, alcohol chronic. Then concurrent systemic illnesses, किसी को malignancy का treatment चल रहा है, toxins का exposure, behavior related HIV, Hep C का treatment तो नहीं चल रहा, या vaccination. Now vaccination also becomes very important when you are talking about any form of demyelination in neurology. Just remember, vaccination and dog bite, these are two things which should always be at the back of your mind. अब ये है एक ओवरऑल टेबल जो आपको सारे DDs, जो आप अच्छी सी एक बार हिस्ट्री ले लोगे, तो these will be the DDs which should be coming to your mind as a whole, right? You can take a screenshot of this. आपको एग्जाम में क्या दिया जा सकता है मैं वो बता देता हूँ. Acute onset within days, GBS. Patient क्या typical या young patient young patient, आवाज आ रही है? Is the audio clear? Is the audio clear? Okay. So young patient presenting with acute onset quadriparesis, usually with loss of power and tone, and ascending to an extent that even at the end of the day, respiratory muscles might be involved. So that is a prototype of Guillain-Barré syndrome or acute inflammatory demyelinating polyneuropathy. Other illnesses which might present like this is porphyrias, polyneuropathy, critical illness, and then diphtheric and thallium. These should not be very important until you are a like core medicine fan, but GBS should not skip your mind. Subacute onset, just remember persisting nutritional deficiencies like B12 deficiency, B6 deficiency, paraneoplastic syndromes. These are the important ones in subacute. Let's say onset from weeks to months. This was earlier one was days. Remember the differences. Days, this is what is coming to you. Weeks to months, these two. Now you have a chronic course. So in chronic, the differentials we predominantly are getting is might be CIDP. It's just recurrent GBS, it is actually CIDP. Presentation is almost similar, but this is over months. And then something is like it comes and goes. The power, it's like it happens repeatedly. So there is something called as a repeated GBS also, which that has to be differentiated from this. It might be HIV, it might be toxin exposure. So in this table of at least 15 things, what you need to remember is GBS over here, a paraneoplastic syndrome in weeks to months, or nutritional deficiency, and then again toxic ones in relapsing course. This is going to give you a clue during HO disease. Am I clear? Can I proceed? I'll pause for a moment. Okay. So coming on the examination part now, see, you need to begin right from the higher mental functions. You need to exclude some things. There is no cranial, there is no focal cortical deficits. Then you look at the cranial nerves. They can see mononeuropathies can be cranial mononeuropathies also. I will show you a slide where just isolated seventh facial nerve involvement might be there, or then a constellation of different cranial nerves might be there. So just don't forget that cranial nerves are also part of neuropathy. So examine all the cranial nerves very carefully. Then you might go on to see. It is not expected that you know how, but at least the answer should be with you that a fundoscopic examination might yield optic pallor, which might be present in vitamin B12 or again malignancy. So that is a clue over there in the eye. We'll go from head. You look at all the nerves. If there is any, once you come to the ward, we can teach you how to palpate for thickened nerves, epitrochlear, supraorbital, then all this has to be class. So I think we'll leave it for that. But just remember thickened nerve. Once you are done with the assessment of the motor, sensory, specifically, and the sensory graded phenomena, including the vibration testing, you need to be very. Once that is done, you continue on to checking the autonomic nervous system. Autonomic nervous system is usually missed in the CNS examination we classically teach. So how do you check that? You need to know the answers. Nobody will be expecting you to do it in the exam, but cardiovagal is heart rate variability at Valsalva maneuver and changes, and then something called as QSAT, which you look at postganglionic pseudomotor function. It is a quantitative pseudomotor assessment test which checks. So you can also check for sweating in different regions. So just remember there is something called as autonomic nervous system testing also, which is not a part and parcel of your routine neurological examination. But once you're looking for neuropathies, specifically those involving the autonomic nerves, this becomes a part of it. Lab testing, now how do you proceed? I'll tell you three main things: diabetes, B12, and serum protein electrophoresis. These are the first three which should be in. However, there is a whole table. Look at the table. I will go slow. Set pattern of the temporal, how it has proceeded. Is it acute? Is it subacute? Is it chronic? Question number one. Question number two, what is the pattern like? Question number three, it is motor, sensory, or, and then you will be looking at the differentials from the table I discussed before. Now, you will confirm this from your physical examination testing. You look at the cranial nerves, you look at the motor sensory part, and you look for thickened nerves, and then a general survey to look at whether there is anemia, there is signs of CRF, thyroid dysfunction, endocrine abnormalities, any hematological abnormalities. So at the end of that, you have a provisional diagnosis. Now let's proceed to investigate from that. So I'll be taking case scenarios so it will become more clearer. You obviously assess a fasting plasma glucose and HbA1c. These are done in conjunction. You just don't leave it at that. Then complete blood counts and peripheral smears, LFT, KFT, 12 folate levels, thyroid function tests, ESR whenever required, CRP, and ANA and heavy metal screen when you are thinking of toxic and maybe autoimmune processes. SPEP, serum protein electrophoresis for multiple myeloma, which might present in the elderly, mimicking so many other disorders. Patient might just simply present with anemia and sometimes some other manifestation, maybe mild renal creatinine derangement, and is also hypertensive. So you need to be very, very clear that don't attribute all nephropathies to hypertension only. You need to look for the cause of renal failure in rapidly progressive renal failure. Not at the first outset you will be thinking कि अच्छा इसको multiple myeloma होगा, लेकिन हाँ अगर उसका creatinine 1 से 2, 2 से 3 jump किया जा रहा है, हर महीने तुम्हारे पास आ रहा है, and you are not thinking of multiple myeloma, then definitely you are missing something. So TSSA antibodies, rheumatoid factor, paraneoplasm, these are what you call as, from here onwards it's all level 2. Level 1. I'll include serum electrophoresis also in level 1. And then once all this is done, you need to begin with nerve conduction, electrophysiology or EMG, whichever is required. यहाँ पे diagnosis नहीं बनता, go on to nerve biopsy. I'll be discussing that also. And auto antibody panel. So these are the three definitive things. One, two, and three, which are done, and they send the report to us in medicine, and the whole consolidation of the case from right beginning of the history, symptoms, and then testing level 1, and then all these things can be done and medicine. So you need to remember when you come to the OPD, see different cases, you will be seeing a whole spectrum of cases we are having over here. Sometimes even referred from Punch, or we refer them cases. So it is a teamwork basically which we are doing. So what I was talking about was antibody. Go through this quickly. Just remember GM1 antibody and Guillain-Barré. However, Willard Fisher, you have GQ1B. These are all MCQs, nothing more than that. So now, what exactly is electrodiagnostic study? We are clear. I just want to take a 2-minute break over here and want some answers also. Are we clear? Evolution pattern, then the history of different type of neuropathies and the patterns, and then the differentials we are generating go about before investigation. Please answer yes if most of it has gone down okay, or I need to repeat something. What? What needs to be repeated? What portion of it is becoming difficult? The question was, are we clear with the diagnostic? Are we clear with the diagnostic approach? That is, the when the patient comes in, you take a clear cut history, the temporal evolution, you have some sort of pattern in your mind, and then how you need to proceed with your examination. You confirm your examination findings and synthesize the whole thing, and then come on to investigation for those differentials. Are we clear with this? Okay, yes. So let's go on to diagnostic testing now. NCV, as we call it, there are three main purposes of doing a diagnostic. In short, to presence, you need to confirm the presence. I'll take the algorithm again, Jyotsna. I'll take the algorithm again. QSAT is not required at your level. Just remember the name. The presence of neuropathy itself needs to, once you have examined by some called NCV, then where exactly in the lesion in the nerve is. Just remember, NCV will help you diagnosing the lesions more in the distal part. You just make a picture in your mind. What is NCV? NCV में क्या करेंगे? दो peripheral part of the limb में, and they'll check between these two conducting electrodes, and then they'll give you a report of how the nerves are conducting, right? So this analyze what the problem is. Like we do ECG for the heart, we are doing same for the nerves. Put two electrodes and then measure the velocities and amplitudes between these two electrodes. Now this will confirm the presence of neuropathy, location, and then nature of the nerve pathology. So I will discuss this in a bit of a detail. What it characterizes is the neuropathic process. Is it sensory or sensorimotor? Then that is important. Sometimes what happens is the motor part is very evident and the sensory part you miss on examination. Electrodiagnostic testing helps characterize the neuropathy as primarily either demyelinating or axonal or mixed. It will localize where exactly it is. Is it symmetric, asymmetric, and what is going on? Is it root, plexus, nerve, radicular plexopathy? And finally, how severe is it and how early you need to be with and aggressive with the treatment. So it is a very important part of examination. I don't think it will be asked you at a level of, but when yes, the most of you are very intelligent, goes on to the Viva. So this is a table which is, listen, I don't want to discuss more PG teaching. However, just remember a few. The point over here are there is something called as a CMAP, compound motor action potential. Normal in demyelination, it will be decreased. However, latencies, these will be decreased in demyelination. So this is a very clear CMAP decreased and latency decreased over here. Right? Now, just remember axonal usually affect part of the nerves. So you can't check the proximal part of the nerves which are hidden under huge muscles or just coming out of the spine just by doing NCV. What you do are F wave and H reflexes, and these will be altered or over here the demyelinating processes in proximal nerves. This is what you need to remember. And finally, fasciculations. Fasciculations and fibrillations, these will be present in axonal processes. So in this table of 20 things, I am giving you just 4 things to remember. Look at the amplitudes, axonal, velocities, segmental, demyelination, H wave and F wave, again, demyelination, fibrillation, fasciculation, axonal. Just that's it. This is a gist of what you need to remember. This is what exactly, this is a simple line picture of what when we look at the report. So this is a normal being given and how it is traveling, and this is how the receiving electrode gets it, right? Now let's look at demyelinating process. At the increased latency, then you get the electrical recording. At this, the second recorder, it is the conduction is also slowed, latency is also slowed, and this feature will defeat this interpretation. See the two peaks over here, the typical of a demyelinating process going on in an axonal. See the amplitudes, it has become so blunted that I was talking about in the last slide. Just remember this slide. CMAP amplitude, latencies, the markings have gone. So simple. This amplitude gone. The latency is not that bad, but again amplitude, right? So this is how the difference will appear. Now we have some limitations of EMG and NCV. Can't study the proximal nerves. They can't be they can be normal neuropathies. Patient कहेगा मुझे tingling, numbness, झंझनाहट हो रही है, उसके NCV में कुछ पिक ही नहीं होगा. क्यों? क्योंकि NCV आपका distal और large part of the nerve को study कर रहा है. वो छोटे receptors को नहीं study कर पाएगा in most of the times. You will be needing a skin biopsy for that. तो NCV might be normal. और पेशेंट को सिम्टम्स होते हैं तो आप कहोगे पेशेंट इज लाइंग टू यू. इट्स नॉट, पेशेंट इज नॉट लाइंग टू यू. द टेस्ट इज जस्ट नॉट पिकिंग अप द disease process. Just remember that. And lower extremity sensory responses can be absent in normal elderly patients also. So the patient comes to you, a very well read man, कि डॉक्टर साहब मैंने तो अपना जनरल टेस्ट कराया था, वहां पे कॉर्पोरेट चेकअप में उन्होंने एनसीवी भी लिख दिया, मेरा B12 लेवल कम आ रहा था, मेरा रिस्पॉन्स खराब आ रहा है. So what will you tell that patient? Well read people, no symptoms even present like this. The final point which I want to highlight to you is these things now which we are discussing. EMG kara lo, NCV kara lo. I took almost 1 hour describing a good history, physical examination. Then the obviously diagnostic testing is not a substitute for clinical examination, and for clinical examination you need to come to the ward whenever the system allows. Look at the patients, look at how to interpret findings, look at reflexes, the sensory part as well, and then you can do a 2+2. It's theory free for clinical purposes, right? I know there is a limitation in the COVID era, but we'll need to do that. Next is now I'll just describe nerve biopsy in a bit of detail. What happens is this is how exactly you do it from the peroneus muscle. You isolate the sural nerve, take a bit part of the nerve. This is how it is being done, and just need to know how and where it is done. The sural nerve is selectively most commonly vasculitis, amyloid, leprosy, CIDP, inherited disorders, rare axonopathies. Superficial peroneal nerve altered sural की जगह advantage और biopsy of the peroneus brevis में तो muscle biopsy भी हो जाती है and it increases the incidence of reporting vasculitis. ठीक है, this is an invasive procedure not done in all cases. Definitive fine. कईयों में हमें फिर skin biopsy भी लेनी पड़ती है. Presence of polyneuropathy, small fiber sensory neuropathy, SFSN is small fiber sensory neuropathy जो मैं डिस्कस कर रहा था, राइट? उसके अंदर आपको स्किन बायोप्सी you will I'll have slides at the end, you will understand more. Now coming on to the basics of treatment. अच्छा, आपके पास पेशेंट आ गया, आपने एक अच्छी हिस्ट्री ले ली, आपने हिस्ट्री को एनालिसिस बनाए, आपने अच्छे से एग्जामिन किया, इन्वेस्टिगेशन का एक प्लान लिखा ओपीडी के स्लिप पे लेफ्ट साइड पे, और एट द सेम टाइम यू जस्ट कांट टेल द पेशेंट आप ये टेस्ट करा के आइएगा. यू नीड टू ट्रीट द पेशेंट साइमल्टेनियसली. if the patient is having painful neuropathy, let's say, you will obviously therapeutic treatment for the cause, you will work that up, but in the first sitting itself, if it is a painful neuropathy, which is the most we face in the OPD, you will start treatment. Now slowly progressive accordingly. However, if it is a rapidly progressing GBS or AIDP, the patient might progress to have respiratory involvement and might even die, might even need ventilator. So you need, and in that case, what is IVIG? Full form of IVIG? Question box. What is the full form of IVIG? Yeah, intravenous immunoglobulin. So what is the cost of IVIG? Approximate cost of IVIG therapy for a course of, it runs into lakhs. That the government is providing, yeah, providing this treatment in all tertiary care hospitals. It is there in LNJP and MAMC. So if you diagnose a patient with GBS, you start him on IVIG, meanwhile get the NCV done, the patient will recover. Remember that. Fine. We have the facility of giving IV. And then symptom management, right? So symptom may, the most important symptom which needs to be, let's say not GBS, now we are talking about painful neuropathy associated with maybe malignancy or diabetes, advanced diabetes. So you give the patient, usually what we start is amitriptyline or gabapentin or pregabalin, and these three drugs should be on your tips. Gabapentin, pregabalin, amitriptyline, these are usually started. And then sometimes SNRIs, duloxetine we sometimes give, and local agents like capsaicin might help. Carbamazepine is many a times used in facial neuropathies. We give Zen. Then opioid analgesics like tramadol, so that nephropathy can be avoided. Botox, mexiletine, these are all therapy. Europe people have their special clinic. So the first line treatments, if somebody asks you, this might come as a exam treatment for neuropathies are these: duloxetine, pregabalin, gabapentin, TCAs, tricyclic antidepressants, and a patch of lidoderm. Second line, carbamazepine, venlafaxine, tramadol. Physical therapies, then you might even need assistive devices. If somebody has, let's say, a totally foot drop, then you consult the ortho people. Again, voice break. I don't know why it's breaking. The network is running. So you need to have splints or assistive devices, then a very safe environment for the people to further with disability to live properly. Footwear at all times and foot hygiene, these need to be stressed. So at the end of investigation, we have 7 key questions which you need to answer. What are these? The first question is, what systems are involved when we are talking about multiple nerves? Motor, sensory, you can take a snapshot of the slide, autonomic or a combination. This is the first question which needs to be answered. Second is, what is the distribution of the weakness? Is it proximal weakness or is it distal weakness? Then is it symmetric, focal asymmetric, versus symmetric? The distribution of the weakness. Then nature of the sensory involvement, if there is sensory involvement, is it the long tract, large fiber, vibratory or proprioceptive loss, or the small fiber, temperature, loss, burning? See, you understand the modality of investigation will also vary. Now, is there evidence of upper motor fiber loss with or without sensory? That also becomes very important. Point number 4. Then evolution, how it has processed. See, these 7 questions have to be answered in your HOPC. Patient will not come to you with answer. Patient will come to you with symptoms. So 5th question is, what is your history? Four weeks to 8 weeks or chronic more than 8 weeks? I told you this evolution is different for different diseases. On an average, if it is weeks or a subacute presentation, this is, or a chronic presentation might come to you. Acute will come to the emergency. And evidence for hereditary neuropathies, just leave this apart. We usually don't tend to give this as an undergrad case. And are there any associated medical conditions? Now, this is very important. Diabetes, connective tissue disorders, HIV, medications जो आजकल लोग केमिस्ट से लेके भी खा लेते हैं. I told you overdose of all medicines now. And preceding events, drugs or toxins. So these will form a history, a key component of your diagnosis. हमें कई बार ना EMG करना. Can somebody tell me, अगर हम proximal limb muscle weakness suspect कर रहे हैं, हम उसको diabetic amyotrophy label कर रहे हैं, please answer this. What is amyotrophy? You people must have heard of amyotrophy. What is it? Is it a disorder of nerve muscle, a muscle, or a nerve? Answers, please. Can you hear me? First of all, am I clear with my question? Due to loss of neurotrophins. Okay, nerve muscle. You need to be, myotrophy is not just muscle, it is more of the nerve involvement which occurs. So EMG will tell you are suspecting a muscle disorder, however it becomes to be a neural disorder. If there is, let's say, entrapment, so distal muscles में EMG से पता लग जाएगा. And finally, limb muscles and radiculopathy. Radiculopathy is again nerves and not muscles. EMG से idea लग जाता है कि muscle. This is a typical picture of hereditary polyneuropathy. A patient. See, look at the clawing of the toes, wasting of the muscle. These are the biopsy findings. I don't think you need to remember all this. Look at this. They take a nerve, then small fibers, and see all infiltrates. This is what happens in vasculitis when it involves the nerves. Can you see any special stain in this? How many of you can identify any special stain? Can you look at the so many over here infiltration? Can you appreciate this? Yeah. Next is, now this is a very pertinent. Yes. This is a very pertinent question when neuropathy is present with facial nerve involvement. Facial nerve involvement, along with either generalized or per se facial nerve involvement might occur in a GBS variant. What is the name of the variant of GBS which involves the facial nerve? Answers. This is an MCQ question. Which variant involves the facial nerve? AIDP is the name. Of GBS. There are variants of GBS. Anyways, CIDP might involve Lyme disease. Sarcoidosis might involve. Sarcoidosis coming with facial nerve involvement, and then HIV. Enough sun variation in Bhavika. Good. It's given in the table. Once you go through your text. So now, when we come on to diabetes, there are patterns with diabetes. We usually ask this at the PG level, but good Viva at undergrad level, there are 7 main patterns. It might be ophthalmic pattern. The most polyneuropathy, motor plus sensory, which happens, the one at the bottom, that is the most common. This is the most common. You might get a ophthalmoplegia. You might get acute diabetic mononeuropathy, burning and tingling in the sole of the foot. You might even get thoracoabdominal. Somewhere on the both sides of the page you are getting pain. Then multiple mononeuropathy along with radiculopathy, and this is very important, autonomic neuropathy. Patient को gastroparesis हो रहा है, patient को genitourinary involvement हो रही है, impotence की history है, long standing diabetes में, you should be suspecting autonomic neuropathy. So and 2, these are very important in diabetic neuropathies. Polysymmetric polyneuropathy, motor plus sensory, and autonomic neuropathies, right? Just a moment. So let us discuss some case scenarios to be clear. Have you prepared your cases? Has anybody prepared? Make them the presenter? You can discuss. Just a small theoretical virtual case scenario. I'm waiting. Can small case scenario? So should I proceed with the predetermined set of case scenarios? Is the audio clear? Okay, so we'll proceed. So this patient had some skin lesions, obviously at the back. There is a bilateral parotid enlargement. The fellow picture changes, but he also had now paralysis due to involvement of the 7th cranial nerve. Facial palsy is having. There is a bone destruction of terminal phalanges. Look at the lacrimal glands, they appear enlarged. So, node and you get a granuloma. So I think the answer is very clear. Yeah, sarcoidosis. And you get a positive Queen test also. although it's not being nowadays. So now the patient is actually having sarcoid, and the presentations are so protean. It began with skin lesions, and 7 facial, going on to this, like rhymal gland hypertrophy, and then biopsy of the nodule and adjunctive testing, and you have a diagnosis of sarcoidosis. But remember, this is a whole long drawn process. Until you sit with the patient, take a very good history. Yes, need to take a very good history. Don't miss findings. Be very clear in the back of your mind. वो जो chapter पढ़ते हैं ना हम, SLE, rheumatoid arthritis, then sarcoidosis, multi-system disorders, वो manifest as either neurological or cardiovascular or GI systems. So those should not be forgotten. So I took this first, right? Cranial neuropathy with sarcoidosis. Next. Answer is written on the slide. Let's look at how PAN. You remember what is PAN? Not micropan, but PAN. There is a sudden occurrence of foot drop while walking. Involvement of the peroneal nerve. The gentleman, there is a, he falls down. He comes to the physician, or and there is not just lower limb. There are other nerves which I told you always draw a skeleton. This is the pattern which was elicited by obviously a physician, not an orthopedist. That this is the pattern, motor and sensory or overlap, which has evolved. Look at the pattern now. What happens is the physician also asks for myalgia and or arthralgia, abdominal problems, anorexia, fever, weight loss. Checks for nephropathy. No audio. Is there no audio? Are you getting the audio? Okay. Somebody had written no audio. So the after this event of foot logical examination and a general examination, you look at, I'm sorry, the slide changed. The pattern of weakness, one, then you look at the nephropathy. Urine examination testing, you patient look, there also is a evidence of. Now, before going on to a angiogram or a CT angiography, you look at the fundus, eyes. These will yield a lot of things, right? And then there is an angiogram showing a aneurysm of small mesenteric vessels. Started developing head, ocular disorder, and convulsions. It should not be that late. A good physician should pick it up at maybe this stage or maximum this involvement. Shouldn't let the disease progress to this. यहाँ तक आ जाओगे तो then anybody can pick it up. Then it is evident that this is vasculitis. Nerves over the renal area, obviously vasculitic involvement, hypertension, nerves in the brain. Now it is going on to aphasia, hemiplegia. Finally, if it is picked up that late, then obviously you're not an astute clinician. Pick it up early. By the biopsy, there is an infiltratory cell infiltration and fibrinoid necrosis of walls of small arteries in various organs. Any organ biopsy will yield this. So, what is the diagnosis over here? It's written there, PAN. This is how PAN will present with mononeuropathy multiplex. Is this clear? Can I proceed? So this is the prototype case. Now let's look at what we were talking earlier. This gentleman history of, I told you it might be acute or chronic. It might occur with arsenic, it might occur with lead. So there is a history of nausea and vomiting. Somebody poison him. There might be, these are different scenarios. There might be a history of rat poison ingestion due to suicidal intent, or some people use copper utensils for a long term, and manufacturing of country made liquor that might have arsenic mixed up, right? So these are arsenic, rat poison in arsenic. Lead can also be an implicating factor. Now there is spotty alopecia also in thallium poisoning. Lead poisoning, just look at the appearance and a 24-hour urinalysis. So these are just clues we are discussing, not the whole case. Has been, how can we come to a diagnosis of something like PAN, as it can have such varied presentations? What should be the approach? It's a very good question. The approach in PAN is determined when you analyze the history of the patient. You have I'll go back to the slide. This is a question being put up. So approach should be, the patient is presenting with multiple nerve involvement, some of which are manifest and some of which are not. So, and it is a subacute course. Acute, it's not acute, it's rather a. So the list of differentials which we had generated in the beginning should always alert us to the possibility of vasculitis as being a etiology. Now, vasculitis, we should remember, it should be large, medium, or small vessel. So when we are looking at medium or a large vessel vasculitis, there might be, or micropan mein small vessel vasculitis, there might be. So once you go beyond nerves, think beyond nerves there, look at the kidney, look at the fundus, look at the brain. When you look at the constellation, make a Venn diagram of what is happening in the nerves, what is happening in the brain, what is happening in the kidney, elsewhere. One or two main differential diagnoses. You will not be missing this. Although it might be difficult, it won't be given to you at a UG level, but just understand and synthesize. Coming of a multi-system disorder is difficult. But with practice, with slowly seeing patients, steadily coming, looking at the wards, seeing so many different patients, most of you would be able to recognize this. It will bring confidence to you once you see. So look at this. This is a patient having autonomic symptoms. The patient gets up from the chair. I think I should have hidden the answer at the top, but still let it be there. The patient gets up from the chair and starts having faintness and dizziness. So what you look at is, you check for autonomic instability, you check for orthostatic hypotension. Whenever somebody tells you that उठते ही चक्कर आने शुरू हो जाते हैं, you always go in for orthostatic testing in the OPD itself. 0 minutes, 1 minute, 3 minutes, and maybe up to 5 minutes. Let the BP apparatus be there and check. If there is a significant fall of 20/10 in both systolic and diastolic, or either of the two, you go in enhanced. Second, the patient also complains to you of having GI autonomic symptoms. अभी तक हमने polyneuropathy discuss किया था. I am discussing autonomic overlap. So the patient now says, along with this, there is also diarrhea and constipation, and sometimes impotence. You will have to ask. So there is an overlap of autonomic nerves in two different systems, and along with ulcerations of leg at different areas. You are now thinking of a multi-system disorder which is affecting the autonomic nerves. Look at the age of the patient. So next you get a investigation done. Let's say you get a protein electrophoresis ordered. Here you are getting a spike. Do people understand what is a M spike? This is not exactly a M spike, but just remember you will get a monoclonal spike. It's a spike over here. Significance is not there because I haven't taken the quantitative scales, but you are definitely getting a spike, and rather two spikes. And biopsy specimen of peripheral nerves. Now you look at the biopsy of the nerves, it is all showing Congo red staining with the myeloid fibers. So you go back to the patient, ask in retrospect, did he have any? Now a myeloid can be primary or secondary. So you go back to the patient and look at the history. Did he have anything which predisposed him to develop a scenario, some other disease? Be primary. Show to you in the biopsy also if you subtype the fibers. So this is what it is, again neuropathy, autonomic neuropathy that the patient is presenting, but the final diagnosis is amyloidosis. This is the charm of medicine, that you diagnose diseases with such varied presentations when you come across the whole spectrum of practicals. Yeah, right. Primary amyloidosis is more likely, Bhavika has answered. One more case. So here, peripheral neuropathies, we are taking the chronic ones, metabolic, toxic, and how will they present? This is just as a reminder that I am repeating this, not of one patient, but a whole spectrum of patients. This is a dipstick test which is coming positive for diabetics, obviously. Look at the face, chronic alcoholics, uremics, and drugs. Remember these as it disulfiram, though we are not using that much. Vincristine, which we are using. And how will the patient present? Glove and stocking presentation. Loss of position slowly if there is dysesthesia. There is a loss of ankle jerk. There's a foot drop on this side rather, not on the other side. Loss of furrowing, open eyelid, and then patient flees off the feet, burning sensation. Enhanced vibration testing, this is lost. So on pinprick, you test the sensations, you check for vibration, you analyze the history, you look at the gait, you look at the jerks. Obviously, this cranial neuropathy, you will come to a set of three most common differentials: diabetes, alcohol, uremic. So I think the whole spectrum of polyneuropathy, mononeuropathy multiplex, and isolated cranial neuropathies pertaining to different cases which might be commonly seen in medicine ward OPDs, and what is expected to you from the as an MBBS candidate in the exam, the whole history has been discussed. This is a case, I think, which might be taken as a distinction case. There are things called as Tangiers and A beta lipoproteinemia. This might come in quizzes or something, and then tendon xanthomas. These also might present sometimes as rare causes. Not a very common thing. We'll skip this. So thank you for patiently listening. I think we can call off the class now. Thank you so much.